I do now invite our National Treasurer, Dr. Alok Bandari, sir, is present. Dr. Alok Bandari, sir. Yes,
Yes,
please.
please. Yes, Nandish, good
for your
evening.
greets.
Well, good evening, friends. I think our
Sir, you are not audible.
Dr. Ruchira HSG platform and also. Am I audible now?
Yes, sir.
Yes, you are audible.
Yes.
I think, am I audible? I play up that it is always nice initiative by the veteran under the leadership of Dr. Basuraja and with the next line of Dr. Nandish, Sumita Naik, Priya, and veterans like Raghunath ji, Sunil, and all. Bangalore team has been at the core of all the activities at IAP level, and I'm really happy to be associated with Team Bangalore and Team Karnataka. My best wishes to you. And today I'm sure you'll get a very good feast by my younger brother and colleague, Dr. Mukesh Dhankar in hematology. And I'll request that we should not be coming much in the way of the science and the viewers. Thank you, please. Thank you.
Yes. Thank you, sir. So to keep the science ahead of all others, so we will now start the session. We thank the presence of all the past IAP Karnataka presidents like our Ashok Dattar sir is there and all other senior leaders are. I cannot take all the names. And I now request our chief guest, Dr. Veerbhadrappa sir, to introduce our speaker of today, Dr. Mukesh Dhankar, and kindly open the academic session, sir. Dr. Veerbhadrappa sir.
Sir, unmute.
Veerbhadrappa sir. Unmute, sir. Veerbhadrappa sir.
Sir, you are muted. You are muted, sir.
Sunil Kumar, unmute. Yes.
Hi.
Good evening, all stalwarts of IAP, Central IAP, State IAP, and members of the IAP Bangalore branch. It is a great initiative for the benefit of practitioners as well as postgraduate students that IAP Bangalore has initiated this webinar series. So today's topic is on anemias in children. So it is a common problem which will be discussed by our eminent speaker, Dr. Mukesh Dhankar, who is DM in hemato-oncology and also working as professor in Kalavati Saran Children Hospital under Lady Hardinge Medical College, New Delhi. His special areas of interest are in hemolytic anemias and leukemias. So in our country, 2 to 3 years, decades ago, we used to see a lot of PM cases like kwashiorkor, marasmus, etc. Invariably, they were all associated with nutritional anemias. After conquering these problems with the introduction of ICDS, better economic performance, and with all good health facilities, the kwashiorkor marasmus are not seen in day-to-day practice. But what we are seeing in day-to-day practice are stunting and anemias in our children. Anemia is prevalent in almost 50% of our children according to latest NFHS data. So it is a great nutritional burden to our children, which needs to be addressed by the government of India, state government, as well as the intervention should be advised by the IAP national body. And the national body of IAP has also taken this initiative by taking community program like the Anaemia Mukt Bharat, which is also under government of India. And today we are seeing children who look very normal, like they are short and light in weight. But if you examine, most of them are anemic. So which needs to be screened in school health program as well as in our practice also. This program is also encompasses ICDS, school health program, and the academic bodies like Indian Academic Pediatrics. So anemia in children has got a lot of bearing on child health also. So its school performance is also affected. Cognitive functions are also affected. And they look very much normal, but what is the underlying cause we should analyze? It may be even simple worm infestation also. So of course, the albendazole and other things are also given under national worm infestation program. So let us hear from our eminent speaker, Dr. Dhankar, about the importance of knowing and analyzing the anemia in children for the benefit of our practitioners and the postgraduate students. Sir, can start your
Thank you very
slide
much
sharing,
for
sir.
your wonderful introduction of the topic, Dr. Veerappa sir. We are very grateful to you for your presence here.
Thank you, sir.
Dr. Mukesh Dhankar sir, over to
Right,
you,
sir.
sir.
Right.
Start that.
So, I would really like to thank IAP Bengaluru for this opportunity. I would not like to take the name of all the respected senior IAPians, colleague IAPians, but I would definitely like to thank Dr. Nandesh for giving me this opportunity and IAP Bengaluru to giving me this opportunity. So, coming on to the topic, my task is to talk about nutritional anemia in day-to-day practice. I hope my slides are visible and I'm audible. Yes to
Yes,
both?
sir. Yes, sir.
Right.
Yes, sir.
Right. So I'll not bore you with too much of theory. I'll try to take you through a case journey, and I'll try to keep it interaction based. So we have a Rishabh who is a 4-year-old boy. He's a resident of Delhi. His chief complaints are exercise intolerance, easy fatigability noticed since last 6 months, and history of craving for soil and wall plaster. He is exclusively vegetarian, occasional patches of worms with stool. He is a second born to a non-consanguineous couple. There is no family history of blood transfusion, gallbladder stone, jaundice, or surgery. On physical examination, there is pallor. Rest of the systemic examination is in normal limit and anthro is also preserved. So which investigations would we want? Dr. Nandish, can we interact? Is it fine?
Yeah, okay, sir. As you please.
No, whatever you feel. So any resident or anybody who would like to share his or her experience? I've given a brief history. Anyways, we ordered a CBC. Here is what our CBC has to say. These are the normal values, and these are on the left side we have the values which the child had. So we see that his hemoglobin is on lower side, 6.4 gram deciliter. Platelet count is increased. RBC count is decreased. MCV is decreased. RDW is increased. And retic is also decreased. We went ahead with our peripheral smear. So this is a flowchart which we classically use. This is very important. So in this, only one lineage was affected. So all other lineages were fine. MC was on a lower side, retic count was on a lower side. So probably we are dealing with this box. This was the PS in which we have classical microcytic hypochromic anemia. If we have anisopiclocytosis, also anisopiclocytosis means variation in size and shape. So classical diagnosis of iron deficiency anemia. So let's see what is this iron deficiency anemia, what is the burden of it, and how we can diagnose, treat, prevent it. So as per WHO, anemia is defined as a reduction of the hemoglobin concentration or RBC volumes below the normal range of values for that given age and gender. These are various age groups, and these are various age groups, and these are the various cutoffs for anemia. So for the common age group in which children's, which we deal most commonly from 6 months to 59 months of age, if the hemoglobin is less than 11, we label it as anemia, whereas it is further subcategorized into mild, moderate, severe. So let's see what is a global scenario of it. So in children's between 6 months to 59 months, we see that the whole of India is having prevalence of anemia more than 40%, but it could be 60, 70, 80. Let's see what that is. So if we see the Indian scenario, this is of all age groups. So if NFSH5 data, which was done in 2019 to 2022, we accept these two states, some states in Northeast and Kerala, whole of the India has a prevalence of more than 40% of anemia in India. If we see for the children's between 6 months to 59, except Kerala, whole of the India has prevalence more than 40%. So what is the trend finally? So in children's between 6 to 59 months, we see a rise to 67.1% from 58.6% in NFSH4 data. And the girls age 15 to 19 years, we have the prevalence of 59 to 59.1%. So here I would like to stop and ask our senior respected IPNs that in spite of all inputs from the government, private practitioners, NGOs, we talking on these webinars, we also talking in various conferences, why is this prevalence of anemia not decreasing? In fact, it is increasing. Can we, Nandi sir, have discussion over it for 2-3 minutes? Anybody, sir? The prevalence of anemia is in fact increasing. It's not decreasing. So I would like, yes, sir, please, sir.
Maybe it is refined food and lack of micronutrients.
Right,
Even
sir.
in our soil also, I think there is a deficiency of all these zinc, iron,
Right.
other
This
micronutrients.
right, sir. This is one of the definite reasons, sir. Anybody else who would like to comment on it? Why is it increasing? We are doing everything possible. Still, it is increasing.
Well, Dr. Mukesh, I would like to point out that what
We have compromise in the quality of iron being supplied by the government. Across a country, the iron is freely available in the government setup, but then definitely its absorption and quality is a serious issue.
Right, sir. Point well noted. It could be one of it.
Dr. Dhankar, can I also join over here?
Sir, please, sir.
Sir, I started the iron folic acid supplementation program in Delhi and then followed by Government of India. The compliance of our pregnant women, compliance of our adolescents, compliance of my students to the iron supplementation is very poor. You go to the schools, we used to distribute tablets of iron, they will throw them into the drains and not take it. So this is the one reason our supplementation program is not working. Compliance is very poor. The second reason for this is our protein intake is also very poor. For making hemoglobin, you just don't need iron, you also need proteins. In the vegetarian diet, we have a very small amount of proteins available to make hemoglobin. So both iron deficiency happens and both protein deficiency happens, leading to all these issues. And third thing is definitely deworming program is also not working. Worm infestation is also another reason which causes anemia in our children and adolescents. These are the three basic reasons. And the fourth is Junk food takes away most of our things. Rather, it causes more of iron deficiency. Thank you, sir.
Right, sir. So all points are totally valid. But if I try to summarize and put it in a better refined or polished way, I would like to say it's not just a medical problem. It's a social problem. It's a dietary issue, nutritional issue. It's a program issue also. So key points should be that the child should be exclusively breastfed till 6 months of age, then appropriate complementary feeding. And as Kapoor sir just mentioned, junk food and all these things should be an important aspect of it. Then there could be repeated infections, acute watery diarrhea, worm infestation. Dr. Kapoor also mentioned that a deworming is important. Another important could be that the mother itself could be having low hemoglobin. Then the late diagnosis, and which Dr. Kapoor specifically mentioned, very important, implementation of program is weak in the form of compliance, follow-up, diagnosis. So all these things combined, when we combine, we see that the prevalence of anemia rather than decreasing is increasing. So we should strengthen each and every aspect rather than just focusing on diagnosis and treatment. Every aspect is important. Thank you for the inputs. So I'll talk specifically about what is this iron deficiency anemia. So worldwide at any given moment, more individuals have iron deficiency anemia than any other health problem. Clinical features, we all know, it could be easy fatigability, shortness of breath, lethargy, drowsiness, dizziness, headache, decreased alertness, palpitation. In the signs, you could have pallor, angular cheilosis, beefy tongue, kilonychia, tachycardia, respiratory distress, and also we, in very severe cases, we may have congestive heart failure. So how do we diagnose? So these are the current guidelines. There may be some variation in the opinion of other doctors, but the guidelines categorically say it is based on dietary history, clinical features, and a peripheral blood picture suggestive of microcytic hypochromic anemia with anisoepicytosis. And we see a classical triad in CBC of low MCV, low MCH, and low MCHC. A diagnosis is also confirmed in a clinical setting by assessing the response to empirical iron therapy. So we just need the dietary history, clinical examination, a CBC in which we see the hemoglobin, these RBC indices, and peripheral smear. We don't need anything else. And if there is a response to iron, the iron deficiency diagnosis is confirmed. Other investigations, yes, they may be needed, but when do we need it? When an alternative diagnosis cannot be excluded clinically, we are suspecting it, or in children who fail to respond to iron therapy. So upfront, other investigations are not merited. In these two conditions only, other investigations are merited. So which are these investigations? One of them, the most commonly used one, is ferritin. It's a reliable indicator of body iron stores. So without infection, in less than 5 years of child, if it is less than 12 microgram per liter, it is suggestive of iron deficiency. For more than 5 years, if it is less than 15, and with infection, any age, if it is less than 30, this is suggestive of iron deficiency anemia. So with infection, the cutoff is slightly higher. As we know, ferritin is an acute phase reactant. So with infections, it may increase. Others are the classical iron profile, the part of iron profile, the iron, total iron, serum iron. If it is less than 40, it is suggestive of iron deficiency. The total iron binding capacity, if it is more than 350, it is suggestive of iron deficiency. Transferrin saturation, if it is less than 12, it is suggestive. In children, it is suggestive of iron deficiency. There are some newer red cell indices, very important. So one of the most commonly used is the reticulocyte hemoglobin content. If it is less than 29, it is suggestive of iron deficiency. This is really wonderful newer red cell indices because this just does not get affected by inflammation. And in a 7-part Coulter CBC, now this investigation is a part of it. It's by default there. So if in a 7-part Coulter machine is there in our hospital, this would be given in the CBC report. Other is soluble transferrin receptors. Soluble transferrin receptors are derived from actively developing red cells and reflect active erythropoiesis. If it is more than 27, it is suggestive of iron deficiency. Another novel parameter is percentage of hypochromic red cells. If the total percentage of the smear which we see under the microscope, if it is more than 5%, then it is suggestive of iron deficiency anemia. Then free erythrocyte porphyrin levels, not commonly available, but if for less than 5 years, if it is more than 70, it is suggestive of iron deficiency. For more than 5 years, if it is more than 80, it is suggestive of iron deficiency. Bone marrow studies are not merited and not needed in the iron deficiency anemia cases. So what is the order seen in iron deficiency? This is the order. First, if we just see the chronology, the first there would be decrease in serum ferritin, followed by the decrease in serum iron. Then there would be increase in iron bending capacity. Then there would be increase in free erythrocyte protoporphyrin. And at this time, the anemia would manifest, followed by increase in RDW, decrease in MCV, and decrease in MCH. Another close differential is THAL, which we differentiate by RDW. Three most parameters: RDW, Menzer index, and RBC. RDW is increase in iron deficiency, vis-a-vis in thaltrate it is normal. Menzer index is increase in iron deficiency, but in thaltrate it is decreased. And RBC count is decrease in iron deficiency and increased in thaltrate. Now coming on the treatment, very, very important. The first and the foremost is nutritional counseling. In this, we have to enforce and we have to counsel the parents that exclusively breastfeeding for the first 6 months is the most important aspect for prevention and treatment of iron deficiency. Followed by starting appropriate complementary feeding at the appropriate time. We know these are the foods which are rich in iron. So the thing is, how can we increase the absorption of iron from this vegetarian source? So we can add vitamin C in the form of giving citrus foods, giving amla, adding lemon, so that the absorption of iron increases. Also, we can decrease the phytates by fermenting, soaking, and sprouting. With this, the phytates decrease and the absorption of iron increases. Now coming on to the oral iron medication, the goal of therapy for this iron is the correction of hemoglobin level and also to replenishment of the body iron stores. So route of iron is oral. It is a route of choice almost always. Oral iron may be initiated based on history, MCV, peripheral smear, which I mentioned earlier. It is a safe, effective, economical, and leads to rapid improvement in hemoglobin if administered in correct dose and followed up appropriately. It is convenient for parents and well tolerated by almost all parents, and parental iron is rarely required. There are various iron preparations. The ferrous form is the one which is absorbed from the GI system. The most common ferrous iron preparations are ascorbate, sulfate, fumarate. And but the important aspect is when we are prescribing iron, the amount of elemental iron the preparation should be noted, and the dose should be calculated according to the parental iron, elemental iron. All these three oral iron preparations have essentially equal bioavailability. So there are ferric salts also, but ferric salt doesn't have any greater efficacy than the ferrous ones, because the ferric would have to be converted to ferrous first before it would be absorbed in the GI system, and it has to be given 3 times, and it's relatively expensive, and the profile is almost similar in terms of efficacy and side effects. There are various others like colloidal iron, carbonyl iron, and amino acid chelated on ferric or ferrous forms. So overall, they are almost similar. But the most important aspect of, rather than picking and choosing which form of iron, it is a compliance which is the most important aspect. So this is recommending the prevention. So this is another important slide. So regarding prevention, the American Academy of Pediatrics and also our NNF, National Neonatology Forum, they say that if the child is preterm or low birth weight, we should start iron at 2 to 4 milligram per kg per day from 2 weeks of age, maximum 15 milligram, and that should be continued till appropriate complementary feeding has been established. This is by UP, and NNF says till 1 year. And for term children, we should start at 4 months of age at 2 milligram per kg, 1 milligram per kg, and should be given till appropriate complementary feeding has been established. So dose and schedule, therapeutic dose is 3 milligram per kg per day, usually single. Empty stomach absorption is best. If there are doses higher or there are some GI upsets, then it can be divided twice and given after feeds. But empty stomach once a day is the preferred way of giving iron. And another aspect is iron should not be administered with milk, curd, calcium syrup, tablets, and is best given if with water if needed. Tea, coffee, drugs interfering absorption such as PPIs and antacids should also be avoided with iron. Duration, traditionally 2 to 3 months after hemoglobin normalizes, which is usually 3 months. Before stopping the therapeutic dose, one should ensure that the family feeding practices have been rectified. Very, very important. Since iron prophylaxis is recommended till adolescent, the prophylactic dose should be administered as recommended by the national program. Another important aspect, once the anemia has been corrected, that does not mean the child need not take the prophylactic iron once a week dose, which is as per Anemia Mukt Bharat. The child should continue taking that. Response to iron. This is how we see within 24 hours, we see that there is decreased irritability, improved appetite. Within 72 hours, reticulocytosis starts and hemoglobin starts rising from the day 4 and is evident by first week. And if the rise is less than 1 gram after 4 weeks of regular therapy, it is a point of concern. And hemoglobin rises on average 0.25 to 0.4 per day during the first 7 to 10 days, and thereafter a slow rise of 0.1 to 0.15 gram is seen in hemoglobin. Now, how do we reassess these children after we have started the therapy? The timing for the schedule for follow-up varies on the degree of severity. For severe anemia who did not receive blood transfusion, we review on day 7 for CBC and clinical evaluation, and then review on day 14 for CBC and clinical evaluation, or earlier if the child develops any danger signs like edema, fast breathing, lethargy, irritability, or any adverse effects such as vomiting or diarrhea. For moderate to mild anemia, review on day 14 for CBC and clinical evaluation is merited. Subsequently, once the documentation has been shown that there is increase, then the child can be called 4 weekly. And the usual rate of increase in hemoglobin is more than 1 gram in 14 days. By 8 to 12 weeks, hemoglobin rises by 3 to 5, and in most cases, anemia is corrected. Follow-up visits should also be utilized to reinforce the need of food diversity, increase consumption of iron and vitamin C food items, including poultry items like egg, meat, organ meats like liver, fish, citrus food, potatoes, tomato, consumption of tea, phytates, whole grain, cereal, soya, nuts and game, and phosphates should be curtailed. Now coming on to whether parenteral iron therapy is needed or not. So most cases of iron deficiency anemia can be successfully managed by oral iron supplementation. Intravenous iron formulations are preferred in view of devoid of major side effects. Intramuscular route is not recommended as it is painful and can lead to staining of overlying skin. What are the indications of parenteral iron therapy? Poor adherence or intolerance due to gastrointestinal side effects or oral iron. Need for rapid replenishment of hemoglobin or iron stores rather than over a course of several months. Ongoing blood loss that exceeds the capacity of oral iron to meet the needs, like heavy uterine bleeding, mucosal telangiectasia. Iron malabsorption due to pre-existing anatomical or physiological condition, like short bowel syndrome. Coexisting inflammatory state that interferes with iron homeostasis. Chronic kidney disease. Genetic form of the refractory to oral iron, that is IRIDA. Iron refractory iron deficiency anemia. There are various preparations available, but iron sucrose and ferric carboxymaltose are approved for treatment of iron deficiency in India. There is a formula for calculation. I am not going into detail of it. So coming on to the response, there is subjective improvement in uncomplicated cases occurs within few days of intravenous therapy. Reticulocytosis peaks at 10 days. Symptomatic improvement occurs in 1 to 2 weeks parallel to rise in hematocrit. However, the complete response may take approximately 4 to 6 weeks after the dose is given. The follow-up evaluation should be done within 6 to 8 weeks after administration because intravenous iron interferes with most iron studies. Now, what could be the possible causes of failure to respond to iron therapy? Poor compliance, failure or irregular administration of oral iron, Administration can be verified by the change in stool color to gray-black or by testing stool for iron. Inadequate iron dose, ineffective iron preparation, and insufficient duration. And other causes could be like if there is a genetic cause like IRIDA, there is iron refractory iron deficiency anemia, or there is ongoing losses, or there is absorption issues like celiac disease, inflammatory bowel disease, surgeries. So these could be other causes, but the common cause is usually related to drug compliance and side effects doses. So what is the indication of blood transfusion in nutritional anemia? It is rarely required. Chronic compensated anemia, where intracellular volume is maintained despite severely low hemoglobin. Blood transfusion is often dangerous as it increases the risk of transfusion-associated circulatory overload and may delay bone marrow recovery. Indication as per WHO is when the hemoglobin is less than 4 or hemoglobin 4 to 6 associated with cardiac decompensation. So routinely blood transfusion is not required. So coming back to our case, so we started oral ferrous sulfate at 3 mg per kg per day once a day. For monitoring, the follow-up visit for CBC on day 7 was planned as the child had severe anemia and subsequently monthly. Total duration, iron was given for 3 months and dietary counseling was also done. The child is fine and perfect. So to summarize, in most clinical situations, a presumptive diagnosis of iron deficiency anemia can be made based on the red cell indices, blood picture, suggestive of microcytic hymochromic anemia. A classical triad of low MCV, low mean corpuscular hemoglobin, low MCHC for age is consistent with diagnosis of IDA. Response to iron therapy should be documented for confirmation of diagnosis. Serum ferritin should be the first test to diagnose iron deficiency or iron deficiency anemia, where investigative workup is indicated, not in all cases. In situation where serum ferritin results are equivocal, transfusion saturation may be used. Use ferrous sulfate for treatment because the ferrous form is the form which is absorbed from GI system. Use oral dose of 2-3 mg per kg per day of elemental iron for treating IDA, given for up to 2 to 3 months after hemoglobin stabilizes, which is usually 3 months. Use single day dosing of oral iron. Divided doses can be given in case of gastrointestinal adverse effects. While on treatment, patient with severe anemia should be called for the first follow-up on day 7, while patient with moderate to mild anemia should be called on follow-up on day 14. Thank you.
Thank you, sir,
Thank you.
for excellent deliberation. The topic is open for discussion by
Suggestion.
our members. Comment and
Yes, sir. Very important. We need to discuss.
Mukesh Dhankar, sir, in
Sir.
chat box, few questions are there.
Hey, I'll just see, sir.
Yeah, you can go through the chat box. Then we will invite our dignitaries to
Right, sir. Right, sir.
give their comments.
Right, sir.
Sir, good evening. I am Dr. Kotres speaking.
Sir,
Yes,
please go ahead.
Sir, we have got you said the iron should be started at the 2 week of age.
Sir, say that again, sir.
Iron can be started at 2 weeks of the age, the newborn period itself.
Right, sir. 2 weeks is
what is the hemoglobin level that time, and whether it concerns with the preterm and term babies.
Right, sir. So here, what I said and what the recommendation says is that for preterm child, iron should be started from 2 weeks of the age at the dose of 2 to 4 mg per kg per day with a maximum dose of 15 mg till appropriate complementary feeding is established or 1 year of age. This is for preterms. For term, at 4 months of age, it should be started at the rate of 1 mg per kg per day till appropriate complementary feeding is established. This is what I said, sir. And this is what recommendations say.
Okay, fine. Is it any gastric irritation for that age?
Right, sir. So basically, whatever form we may give, gastric irritation or side effects are seen in about 15 to 20% of the cases. Whatever we may give, it could be ferrous, it could be ferric, it could be colloidal, it could be amino acid chelates. So this should not deter us from motivating the child's parents to continue with iron. These are minor things. They usually settle and they should not be the point of concern. These are minor things, and because the benefits are much more than these minor side effects, and which is expected in any form of iron which we give, sir. Some in we may have less, and in some we may have on a slightly on a higher side.
Thank you, sir. Very good comment you have given me.
Dr. Maleshkar.
कुछ हुआ है उनमें क्या कहते हैं अपने
Dr. Maleshwara, sir.
Sir.
Hello. Yes, sir.
Yes, sir.
Sir, like in you heard about RDW, it was less in case of thalassemia minor, I think. It will be increased in thalassemia major, or it is both same in both.
No. Very well point highlighted, sir. So you're absolutely right. In thalassemia major, it would be increased, but in trait, it would be decreased. You're absolutely right, sir. Absolutely right. But in iron deficiency anemia, RDW is increased. So why this happens, I'll just like to, as you have raised this point, I would just like to tell the pathophysiology so that we all remember it for life.
Yes, sir. Yes,
so basically, the life cycle of a normal RBC is 120 days approximately.
Yes, sir.
So it just doesn't happen that suppose the iron deficiency anemia starts today, for example, my diet becomes deficient. So जो पुराने वाले RBC हैं वो तो normal size के हैं. The newer ones are of the smaller size, the old RBCs are of the normal size. So basically distribution, the size variation is there. कोई छोटा है, कोई बड़ा है. So that ways we have a higher RDW. Whereas in thalassemia trait, we do not have a genetic potential to manufacture normal RBCs. So they are by default of a smaller size.
Yes, sir. Sir, good explanation, sir. Easy to remember. Otherwise, I have to confuse between the trait and the major and this one.
Right, sir. So major, yes, big, they are big, no doubt.
Yes, sir. If follow up, you will do only like HB is enough, or you have to do a CBC on follow up for 15 days or 1 month and every month.
So basically, if the thing is, if the child is fine and if we just do hemoglobin, that is also fine. If there is increase, it's fine. We are happy with it. And if there is a response, then it's very even more evident that it is iron deficiency.
Okay. Only once you are enough is to do it 15 days, sir. Afterwards, not needed.
So what we do is, if it is severe deficiency, that means if it is less than 7, we call them on day 7. Otherwise, we call them on day 14. And if there is a documented rise, then we call them monthly.
Well, we don't you see once you see the documented, then you will once in a month you will.
Yeah, that is fine. And but right, absolutely right.
So sometimes the iron will cause, when some children lose motion, some children will cause a constipation. Is there any way to avoid that?
So as I mentioned earlier, in some it would cause constipation, in some it would cause diarrhea, in some it would cause gastritis. In some teenage girls, Dr. Kapoor would be in a much better position. They faint also. So the iron cannot cause fainting. So it's like these are minor things, and we should kind of always motivate कि इनको ज़्यादा सुनना नहीं होता इन चीज़ों को. You have to just say that keep on giving. अगर आप ठीक से देंगे तो डायरिया भी ठीक हो जाएगा. अगर आप ठीक से देंगे तो कॉन्स्टिपेशन भी ठीक हो जाएगा. You have to say these motivating words rather than highlighting these side effects. These are minor side effects.
Sir, considering the transfusion problems, why can't we give a IV? Is there any problem? Because our obstetrics colleague will give left and right IV for all the mothers whenever there is anemia. Can we apply the same thing, or is there some contraindication? Why are
no, sir. This your point is totally valid and appropriate, right question also, I would say. So nothing wrong in using parental iron. The thing is, there are two aspects to it. One is that as long we have been using oral iron, and the response has been wonderful. We did not really felt the need of parental ones, and we rarely only need it as any specific indications. So we have never tried it also. At the same time, I must confess, pediatric patients we have not tried because we are happy with our own.
Okay.
So because we are so happy, so things are fine. Children are getting better, but the parental issues would be there could be reactions. There could be issues, then the abuse by the periphery RMPs who are not valid doctors. These issues would get bigger, because even if we lose a single child out of 1 lakh parental, then it would still be a 100% loss for that family.
Yes. Yes.
That is.
Thank you, sir. Thanks, sir.
Sir, this is Dr. Kishore Baindur speaking. Yeah, we had a wonderful insight into iron deficiency, anemias, and the newer ways of how you should, do some investigations. These were eye openers and all. So, just a moot point that with iron deficiency anemia being so rampant in our country, and for so many years we have been trying to intervene with various methods, Anemia Mukt Bharat, but we have not been very successful as you put it in your initial slides. Is there any role for, say, universalizing iron supplementation, less like, say, vitamin D is being done now? Mothers themselves are anemic, and breast milk is also, though bioavailability is good, it is definitely deficient probably. Most of our children lack iron from various sources. So would you say that there is a role for universal, supplementation in
Yes,
some
sir,
form?
absolutely. Yes, absolutely, sir. The Anemia Bharat class typically addresses your concern. The concern is totally valid. So our diet.
No, just like vitamin D, sir. Now that every child born, term, preterm, everyone does get about 400 international. So can a recommendation like that be made for iron also?
Yes, sir.
They
Yes, sir.
maybe
It
for
is.
6 months or
Yes, sir. Yes,
something
sir.
like that.
Yes, sir. Yes, sir. It's there, and we are giving through Anemia Mukt Bharat. And for newborns, I have mentioned that from 2 weeks or 4 months for preterm and term, because why they have chosen that time is because there is a neither when the hemoglobin falls by that time because of the physiological anemia. So otherwise, the Anemia Book Bharat says so that for particular this age group, this has to be given once a week or twice a week. So in children's less than 5 years, it is given twice a week. Beyond that, it is given once a month. The strength is different. Similarly, deworming is also advised in Anemia Book. It is definitely there, sir, and your point is totally true and valid.
Dr. Mukesh, I just want to add to this.
Sir.
There are three strategies. One is iron supplementation, other is diversification of diet, third is iron fortification. That's the strategy is also being followed under AMB, where certain our dietary things are being fortified. Like even rice has been fortified, like iodine fortification of salt. We tried doing iron fortification of salt, but the color became black and people didn't take it. Now we're trying to make cereals with iron fortification. Sprinklers have been also been added that you can sprinkle iron over there. So these are the other strategies which are being taken care of to increase the iron intake of the population. So just not supplementation, we should go to the iron fortification of our dietary products as well as sprinklers thing that should be available on all tables. If you want to sprinkle salt, you can also sprinkle iron over your food particles. These are other strategies which should be followed, sir. Thank you, sir.
Can I make a comment, sir?
Sir, please, sir.
Hello, sir.
Please, sir. Please, Parmesh, sir.
Yes, sir. The respected chairman and our president and my brother, sister of IAPNs, let me congratulate Mukesh. You have done a wonderful job. Excellent talk and a simple way. And as an environmentalist, I think every increase of 1 degree temperature, there is 25% decrease in the yield, not only quantity of the food and quality of the food. Bangalore, we used to have 28, 29, now we have got 31 degrees now, much higher. In the future, we are going to face a lot of protein deficiency. Not only quantity will come down, quality also in terms of protein, in terms of vitamins, in terms of minerals is going to be less. This has been proved. These 4 studies have been studies are done on rice, soybean, wheat, and maize. So we have to think of the future, how to plan all these things. And this is going to be more problem in future. I think this is something comment for you. So in future, we are going to see the not only marasmus, kwashiorkor, stunting, all these things going to, along with anemia, we are going to see that one. And also zinc has been identified severely.
acroderma enteropathic we used to see earlier. We have to see those things along with the other thing, various things we have to think in the future, how to plan for it. Indian way of eating is the better way, more than any other countries. That's been proved beyond certain thing, and we have to look into that one, supplement the situation. Thank you very much for giving me this comment.
Sir, one question.
Sir, please.
Sir, what about white iron and iron gummies?
So I think you have mentioned in the chat box. So I was coming to that. So basically, there are three aspects of this. One is gummy. Other could be the sustained release tablets of this, or the third one could be enteric coated. So these three forms could be the other forms of iron. So these gummies are sugar coated practically. So what happens? They are not that stable. So they're not that effective practically. So they're not advisable from the medical point of view. Second could be the sustained release. So what would happen? This sustained release, the iron is absorbed primarily in duodenum. So this sustained release would pass through the duodenum by the time they would not be absorbed. So not again advisable. The third could be enteric. They are not disintegrated in the stomach. So their absorption is not also that good in. So these three gummies, enteric, sustained release, iron preparations or iron tablets, or these are not advisable. They're not good.
So white
Yes,
iron.
please. Yes, sir.
White iron.
Sir,
Tessiron and some brands.
No. That tessiron, this absorption is very poor, not advisable at all. Not at all.
Oh, thank you.
There is one more question about teeth staining. Yes, teeth staining is a concern, but if we rinse, but there could be somebody saying, 2 महीने के बच्चे को 3 महीने के बच्चे को कैसे rinsing कराएंगे? Yes, this could be a concern. Rinsing can avoid it, but this is temporary. Once this iron is stopped, the staining disappears. Another question was whether to give at the iron at the dose of 6 milligram or 3 milligram. So 3 milligram is usually sufficient, but if there was a study from British hematology which found that even in adult, giving iron more than 66 milligram per day is not absorbed. So maximum absorption even in adult is 66 milligram. So it's not advisable to give higher doses, but yes, at the same time, higher doses up to 60 or 66 milligram may be given when anemia is severe, or otherwise we want a rapid response, so that may be given, but usually 3. Yes, sir. Kapoor sir has also mentioned that in India we have come down from 100 to 60 because that is the rationale behind it.
Sir, what about the consumption of milk, which parents think that it is very nutritious?
So, बहुत अच्छा question है, sir.
Cow's milk also
Very
sometimes.
So, answer to this is beyond 6 months of age, maximum milk which we advise is 600 ml per day. Beyond that, if we give milk, what would happen? The stomach would be filled with milk, which is low in iron content, and the child would be deprived of appropriate complementary feeds. So maximum is 600 per day. Yes, mother's milk can be continued.
Sometimes the milk as such is a contributory cause for the iron deficiency, because it is most of the time the mothers are giving milk to the children and they are not giving any supplement, any complementary food. And second is once the child start taking milk, he will be deprived of the other nutrition supplements and all that. There is no complementary feed to the children, so they become definitely deficient. In Punjab, naturally, this is one of the great factor contributing to the iron deficiency anemia. So one of the reason is the high intake of the milk as such.
Right.
Second is if the iron is intolerant, even when we divide the doses into the 2 or 3 times a day, so it will remain intolerant. So we have to think it otherwise. If it is intolerant, the division of the dose doesn't mean it will become tolerant.
Yes, that may be a possibility. So in that scenario, what we usually do, we try to change the form of iron. We try to change the brand. If we were earlier giving ferrous, we could give ferric, or we could give colloidal. So we could give iron polymaltase complex, which has a relatively less side effect. So we have to mix and match kind of thing. We have to try different brand, different form, and hope for the best. It is
Somebody has mentioned that the government iron, it is a not very palatable, but it is the compliance which counts a lot. I've been the Director Health Services Punjab, so we were facing this difficulty that the compliance of the iron is a major problem for as an intake.
Sir, the major issue is, to my understanding, is compliance. So we should not highlight these minor side effects. We should not talk too much about this quality and all this, because they are anyhow passed by some कहते हैं ना, agency ने तो pass किया ही है sir. So compliance के लिए what the best we can do as a physician is we should tell them that ये condition है, आपको इतने दिन लेनी है. वो कुछ कुछ बोलता रहेगा, सब सुनना है. काउंसलिंग यही है सर, सुनना है, समझना है, उसको अप्रोप्रिएट एडवाइस देनी है, पर उसको किसी ना किसी तरीके से वो हमें थेरेपी का कोर्स पूरा कराना है और आगे प्रोफिलैक्सिस कंटिन्यू करना है.
Thank you very much, sir. It's wonderful talk.
Sir, one more query थी चैट बॉक्स में, when to suspect iron refractiveness. So iron refractiveness हम जब suspect करेंगे अगर after 4 weeks of appropriate iron therapy at appropriate dose, if the hemoglobin does not increase more than by 1 gram %, then we would think of iron refractiveness. Which weekly prophylaxis doses and schedule? So weekly prophylaxis and doses का schedule का ऐसा है. So up to 5 years we give bi-weekly 1 ml, and for 5 to 9 years we give a tablet once a month which has iron 45 milligram and 400 microgram of folic acid, and beyond that age we give one tablet once a week which has 60 milligram of iron and 500 microgram of folic acid. The colors are different. So one is pink and one is blue. So it is different. We can differentiate. We don't need to read the tablet content each time.
Jai Kapoor sir is asking, combined with folic acid deficiency or vitamin B deficiency, how to?
So yes, we can have both the deficiency at the same time. So the thing is, the amount of vitamin B12 or folic acid in iron preparation is negligible. So if we have dimorphic anemia की दोनों की deficiency, then we need to give separate therapy. Iron, B12, folic acid. We have to give different calculated doses rather than the amount of B12 and folic acid in iron syrups is insignificant. That cannot be counted as therapeutic.
Professor Srinivasan sir.
Why me? They have already discussed everything. It is wonderful talk. Enjoyed thoroughly. Yeah, and all the questions are very well cleared. And of course, it's a simple and elegant talk which covered all aspects of iron deficiency anemia. Thank you.
Thank you, sir. Any more questions from the audience, sir?
Sir,
Sunil
just
Kumar.
I wanted to ask one question, sir.
Sir,
like
sir.
pure iron deficiency anemia in children is almost like 30 to 50% of children will have only iron deficiency. Rest another 30 to 55% will have other associated mineral deficiency or micronutrient deficiency, sir. So my question is, what is this role of, is it playing any role in not controlling iron deficiency, the role of agonists and antagonists in the diet, like zinc, cobalt, copper?
Yes, sir, I totally agree. As I mentioned earlier also, it is
Yes,
just
sir.
not medical problem. It is just not one issue.
Yes,
So
sir.
here, what I was talking about only iron deficiency. I haven't
Yes, sir.
talked about B12 deficiency. I haven't talked about folic acid deficiency. I haven't talked about copper deficiency. I haven't talked about other causes of anemia, hemolytic anemias. I haven't talked about other inherited causes of anemia. So they're also contributing in the prevalence of anemia. So yes, your point is totally valid. These could be the things, but the thing is, we are trying when we are making a public program, we are trying to be most rational, which is most common. How with the minimal things we can give the best output. So yes, your point is totally valid. This could be very much, but we do not have any consolidated data to say how much, how many. We cannot We do not have any data on that, sir.
Thank you, sir.
No more questions, sir. Any concluding remarks, sir? Veerabhadrappa, sir?
Yes, it was an excellent talk and very useful for all of us, and particularly about the duration of treatment and about the preparations, which are, I think, fascinating. Preparations are there, but most of us are tempted to use different preparations. Sir has highlighted about the common ferrous sulfate, which is really good for the day-to-day practice. I thank IAP Bangalore branch and office bearers of the Bangalore branch for giving me opportunity to participate in this excellent webinar. I thank our eminent speaker for his excellent deliberation.
Thank you. Thank you, sir. Thank you, Mukesh Dhankar, sir, for your wonderful deliberations and wonderful interaction with the audience. And I request our Secretary AP Bengaluru, Dr. Sunil Kumar, sir, to give vote of thanks.
Thank
Please.
you, sir. Thank you, Dr. Nandi, sir, for convening this wonderful practical session, we can say. First and foremost, on behalf of IAP Bangalore, I thank the speaker for today, Dr. Mukesh Dhankar, sir. Thank you, sir. And the chief guest for today, Dr. Veerabhadrappa, sir, for sparing your valuable time with us, sir. Thank you, sir. And I thank all the seniors. There was galaxy of seniors. Dr. Parmesh, sir, Dr. Srinivasan, sir, Dr. G. Baswara, sir, Dr. Singarvelu, sir, Ravi Shankar, sir, Sumita Nayak, madam, Geeta Patil, madam, Yogesh Parikh, sir, Ruchira Gupta, madam, Alok Mandari, sir, Dr. Jai Kapoor, Kalpana Datta, madam, Dr. Mallesh, Dr. Shantra, sir, Dr. Kishore, sir, Dr. Kashi, sir, Ashok Datar, sir, Dr. S.V. Patil, sir, Dr. Priya Shivali, madam, and so many of our OB EBs were there in the meeting. On behalf of all the audience, I thank Dr. Nandi, sir, and Dr. Raghunath, sir, whose brainchild is this wonderful session, we can say. Thank you very much, sir. Good night, sir.
Happy Holi also.
Happy Holi to all the
Happy Holi, sir. Thank you very much, sir. Thank you.
Thank you, Sunil, and the credit goes to Dr. Nandi for having a personal touch and making this program very successful event. Thank you, Nandi. We really appreciate your hard work and a lot of good things going there.
Thank you.
Thank you.
Thank you, sir.
Also thank Dr. Sunil for welcoming and thanking the audience. Thank you.
Thank you, sir. Thank you, sir. Good night, sir.
Good night. Happy Holi.
Good night, sir.
Happy Holi, sir.
Take care. Bye.